Now, when we assess the line, as soon as there's flexion, it takes tension out of the line. But these tables are so gosh darn hard. The best way you could do this would be have the legs slightly dangling off, okay? But let's live with the fact that we know we've got a slight flexion here. Now, if we look at the back line, it runs continuous from the head over the posterior cervicals, C7, the erector spinae, bifurcating at thoracolumbar fascia to become ligament, which then becomes tendon, that becomes muscle again. If you use only fascial techniques on the line, you don't clear it enough. You have to use 3 different variables. Now, before we can do that, we have to again assess the ease and bind. He goes up but not down. He goes up but not down. He goes down but not up. Therefore, this segment, which is a body strap, is pulling the line that way. Is everyone with me? Yes. Let's go below the waist. The gluteals are not on the line, but the gluteals are over the line. And even though he doesn't teach the gluteals as part of the line, if we don't do something with the gluteals before or after, fascially, we still may not get movement on the line. But let's leave that alone for a second. I'll leave the ligament for a moment. The hamstrings are the most common muscle of the line. And your assessment will be 2 ways. Pressing to the first layer of muscle to feel its depth, and then moving the line for assessment. Someone do that over here.
Pressing though?
Yeah, how far does it let you press where it stops you at the very first level? And then do it over here. So the questions you're asking is how far it lets me in, and what direction does it go? You're assessing 2 variables. Does that make sense?
Compression.
Compression and direction.
And direction.
Okay, on the surface. Now, what did you assess? And do this side as well, and tell me the comparison between the right hamstring and the left hamstring.
So this is way tougher than this side.
Way tougher?
In the sense, compression, I
You
don't
can't
have
compress
much
it, that's right.
ease here.
And you can there.
Slightly.
So clearly a compressive technique will work on here immediately.
Then,
And I would say without you knowing that, you would always apply a compression technique to this, and I'm going to say already you're disadvantaged.
so
Without even
compression,
checking, see, without doing that kind of assessment, you're already trying to use the same technique on tissue, and one's going to go okay, and the other one's going to go no. Okay. Second, what's the directional barrier?
doesn't
Down, and that one will be up. Watch. It'll be up. Yeah. Now, this is a normal extremity relationship based often on a pelvic obliquity. I'll talk later that the joints are like the other side of the coin for fascia. Muscles in the middle, they're sandwiched between joint and fascia. But that's just giving us a glimpse, isn't it? It's just a little snapshot. Now, if you're to use, okay, so then we're going to go down here and check virtually 0 movement on the line. We can see the bunching of the tendons. So the only way to change that bunching to lift a little bit of the pillow to allow that to go into a better state. But even when I check it, that's it. And there's more mobility on the left than there is the right. Now, clearly, we're also going to, later, we'd be talking about the knee capsule mediating the joint, and we're going to see if a more advanced look in assessment, once you do the single assessments, is to basically do paired up, down, together, apart. Paired up, down, together, apart. They're pulling that way. So I'm teaching you to start to do this, and very quickly you'll be doing that. And that gives you a quicker palpation. But you can't do that if you don't know how to do this. Drop your shoulders as you do it. There, you can feel the relationship. We'll be doing that relationship everywhere. It's a stack of 4 directions using a compound. And then we can we'll be able to do our technique that way. See, things will move quicker. So I've got to keep things simple to start, and then we build. Now, that's a back line that just needs work, and he doesn't even go that way. Therefore, there's one last plane that we can assess. No. Wait. Yes. Rotation. Corkscrew. And he doesn't corkscrew. Okay. Let's go realign this line, shall I? So, probably from a beginner. Yes? Yes. In fact, and as several people palpate, the line will change, but let's have you palpate him first before I change it, because he's a poster child for backline fascial tension. He's wonderful. And of course, now you got to live with the fact that you're going to have thousands of hands on you, but then this is probably a secret desire that you might have had. That's rotation, so bring yourself here. Or put your hand on mine. Just relax, relax. Stops there, stops there. Because when you guys go
up and down, not so bad.
Yeah, well,
sideways.
Up and down is bad.
Compared
to the other plane, please. We don't have any health history, so let's talk.
I had a feeling in my groin region when someone was pressing.
Pain in the groin. Yeah, all right. That's starting to reflect the tension that this boy is under. When we get to the tables, this is what you're going to be doing on these 2 lines. And that's going to take a fair bit of the time. Huh? Yeah, and then you'll come and see how he moves, right? Yeah. It makes sense. Good. Yes, it correlates. Good. So this is going to be a big piece of what we got to do before I can move on, and that means you guys will have to have the table set up. 2 or 3 people getting on. You need to feel it, you need to assess it, and you need to receive it. Everybody has to be touched. Okay, because you've got to feel it in your body as well as do it on the person.
So these were the findings. So his right knee was hyperextended.
Oh, wow, okay.
And then the pelvis.
Wow, and so the tissue's telling us that, isn't it?
Yeah.
Body doesn't lie.
Yeah.
We had exactly this area of hypo.
Not moving.
No, tissue shows it. See, I didn't even look at that.
Yeah.
So, okay, so would you share, sit up everybody. They worked with Joy and wrote down the findings. And go ahead, share the findings.
So his right knee was hyperextended and the pelvis on the right was a little forwards. And he did not move much in the lumbar area while bending forwards.
So our palpation now is reflecting those distortions. Okay. Now, what's going to be the first level learning curve wall is, first, if you can do a single release and feel it, and if not, assess it so that you know it worked. So that then my strategy is the techniques I teach are absolutely simple, but then we stack them into 3-dimensional patterns using the same simple technique. So I've been lucky the whole career. The techniques are not earth-shaking, they're basic, but it's the patterns that are, and the engagement of the simple techniques to get a dynamic change quickly. That's what you're paying me the money for, okay? Or however much you're paying me, because I don't know. Okay, I'm going to go in ease. His ease is up, and it's just me now deciding which hand position I like better. I'm pulling that there and holding it. And now, because this is very tight fascia, duration takes longer. If the fascia is thin, like your lovely blouse in certain areas, it would change really quickly. But this thoracic fascia is tough, durable, made to wear. So I gotta hang for a while. There we go, he's starting to feel something. Yes.
Even right now you're applying force in both the directions, compression also and superior.
It's always two already. Now we wait a second, we take our hands off. I've already stacked, haven't I? Because fascia can't just have one variable. Minimum of two variables in MFR. Trigger point's one variable, but MFR is not. See how I'm framing your manual therapy? I'll take whatever technique you're doing and frame it into a compression tension dynamic to make sense of more of what we're doing with it. Whoa, that's working. You got a nervous system off that, didn't you? What do you tell them what you're feeling?
I got a big release on my lumbar.
Cool. Let's check it.
Yeah, much better.
Now, now, I don't want to go into bind yet. So I'm going to go this way into ease. And this is the first stack that I'm going to teach called a fulcrum, glide fulcrum. So he's now in the ease position, and I'm going to now assess the sagittal up. It's an L.
Okay.
And I'm going to throw the rotation on, which virtually is non-existent. In fact, if it doesn't go rotationally, it's okay. It's so tight here, I have to clear the... Oh, I got another one coming. Here we go. And they just hang in here. This is called Stephen's euphemism, ride the pony. Stay in the saddle. Don't let the thing buck you off. Don't bail out before the time is right. He's got an SIJ issue on the left. You can feel, there it goes, there it goes. It just gave some. So now we'll move it around, take the hand off, and now his nervous system is going to filter this technique. This is as important as what I just did. You are going to want to keep touching and checking. Did I do it? Is it changed? Let me check again. Oh, let me check a third time. And meanwhile, you'll interrupt the nervous system response, which is actually more powerful than that.
So what did
You
you
can see
feel?
breathing has improved. He's much more relaxed.
Question?
What did you feel there?
Well, I could feel the change in the tissues sufficiently, which is hyaluronic acid. It's creating a glide. He, however, will have a little different perception of what I feel. What are you feeling?
So on the left, while it was releasing, I was breathing heavily, and when you released it, my breathing was very...
Yeah. Oh, that's looking
Feel
better.
as if the pelvis also sort of set
Yeah.
down on the.
Yeah, so now that's moving better. We got a lot of work to do there. I'm not going to do the whole session on him. This is what you're going to start to play with. Now, we either can stop here and you play, or I show you two more things.
More things.
Yeah, I knew you guys would do it. Now, we're going to teach a tendon release. The best area on the body to handle just direct pressure, because you couldn't do it here because of where it's at, but is the hamstring tendon. All you got to do is put a flat forearm with the angled elbow down, and you guys are familiar with Golgi tendon organs?
Yes.
Okay. You understand the reflexive concept of a Golgi, a GTO? Yes. It's reading a different force and mass of tension, and it sends an inhibitory message to let go. So your force, it thinks it's under attack or something, and it has to relax. Now, how do you know it's ready to take the tendon and respond? You don't know unless it doesn't respond. If in fact it feels rubbery and recoily, it's not going to work. This side is working. Then I would, because it's accepting the compression, I would hang, we'd wait. That should be, right now that's probably only a 2 to 4, is that correct?
Pressure. Well, how much is the pressure?
Joy?
3.5.
Perfect. If it wasn't working, he'd feel it as a 1 or 2. And when it lets go,